Welcome to this week's episode of Promising Young Surgeon. This week, Catherine Booker joins us to discuss her career as a physical therapist and coordinator of clinical education at her institution. Of course, I'm a huge believer in the importance of hearing from and learning about the journeys and expertise of medical professionals across various fields in the healthcare industry. And so, really excited to chat with Catherine and learn from her today. But before we jump into that discussion, I would first like to talk a little bit about something that I do in my daily life, in my ENT practice, which is globus sensation and chronic throat clearing. So, as I mentioned, I'm a general ENT. I see this a lot in clinic. This is part of my bread and butter, laryngology practice. And the reason that I want to highlight it today is because, in addition to the fact that I actually just love this topic, it's because I like to highlight how much these diagnoses can be determined via thorough clinical history. And so I was trained, and therefore I teach and train others, my junior residents back in the day and now my clinic team, to try and have at least a few working clinical diagnoses prior to even examining the patient based on story alone. And there's something very algorithmic about this workup, which I find very beautiful. So, I'm absolutely one of those doctors who says I do things the same way every time. And I do. Like, you'll see my set of questions, things like that. It is the same way every time, I think, to my benefit and the thorough workup's benefit. So let's imagine a 40-year-old female presents to clinic with a 3-month history of globus sensation. In layman's terms, that's where it feels like something's always stuck in her throat. She cannot seem to get rid of it despite any amount of throat clearing, taking sips of water, etc. It just never really goes away. She did have COVID 4 months ago, and the cough did take quite a while to resolve, certainly after that. Like, it lasted several weeks longer than her coughs normally do. She does not endorse any known antecedent triggers, injuries, or trauma. And so, okay, I'm not going to go into the whole patient visit and put everyone to sleep. That's not really what we do on this show, but I will tell you a framework for the history-taking portion of this workup. So that's all information that, let's say, I got from the referral paperwork and from her visit with her PCP. So here's what goes into my line of questioning. Well, I can tell you right now that the top 3 causes of globus sensation or chronic throat clearing in adults are 1, postnasal drip, typically allergic rhinitis, although it could be, vasomotor rhinitis or other causes of rhinitis. Number 2, laryngopharyngeal reflux, which is also called, heartburn, basically where you can feel the acid come back up into your throat. Or 3, cough variant asthma. And there are people who maybe didn't even have asthma before, but as an adult, they independently developed this cough. That could be a presentation of cough variant asthma in an adult. So that means that basically informs the first 3 questions. Number 1, any history of environmental allergies? We can always do things like consider allergy tested if there's a question. Any history of reflux? Again, if called into question, there's objective testing that exists, pH probe testing, things like that we can do to objectively evaluate yes or no. There are things such as silent reflux, which maybe we can get into on another day. Number 3, any history of asthma. And even if they say, okay, well, no, there's no history of asthma, and this person's had a complete exhaustive chronic throat clearing workup without an identified etiology, it's not crazy to obtain like a set of pulmonary function tests or PFTs to officially rule out cough variant asthma. Okay, so that's that first little chunk of questioning. But then now we look at other interesting details about the history. So I ask, any shoulder or cervical spine injuries? Examine the medication list. Look for any drying medications. Like, certainly people as we get older, but we're still taking medications over the counter or prescribed that have anticholinergic side effects. Those are very drying. Of course, we look for things like ACE inhibitors or ARBs, for their cough side effects. And then another huge question is, what's your daily water intake? And what's your daily caffeine intake? So, again, we don't have time for the deep dive today, but I say this to kind of share, some of these questions you may not automatically think of if you were thinking, it feels like something's stuck in my throat all the time. Well, why am I asking about their cervical spine? I'm going to share just a couple times where clinical history cinches a diagnosis and is very critical to obtain. And not only that, but I'm going to give a couple examples where maybe this person even undergoes laryngoscopy in clinic and it looks grossly normal. It looks okay. And so they're just told, you look great, get out of here, bud. And, they're kind of sent away like it's a little unsatisfactory. And also it hasn't answered the question of what's happening. So one example is, let's say, like in the woman in the example that I've shared today, she had a prolonged post-COVID cough. Okay, well, months of coughing, that's a risk factor for basically the equivalent of pulling a muscle in the front of your neck or pulling a laryngeal muscle from the anterior laryngeal musculature. And so something like that would be on my differential just based on that story. I had a woman, for instance, in her 40s who came in with this globus, so no injuries, no trauma, no shoulder injuries, no C-spine issues. But when I got to that last question, which I ask everyone about their water and caffeine intake respectively, and then the balance between the two, she was drinking 4 large Mountain Dews per day and no water. And also she had had bronchitis several months ago, and the lingering cough never really went away after that. So guess what? We compensate until we don't. And so what we recommend in terms of daily water intake is 60 to 80 ounces of water per day with matched increase for every ounce of caffeine. So, of course, in her case, she's quite off from the mark. But often I'm counseling people, hey, you're only at that 40, 50 ounce of water a day mark, and then you're doing a lot of coffee or soda on top of that. So let's get you closer to our goals here. In a similar vein, I had a very, very nice gentleman, super active, very fit in his 70s. So he was an avid hiker, he was out every day. Like he was really actually in excellent physical shape, but he came in with Globus. Of course, we do scope these people. So in all these scenarios, picture they get a scope and there's not anything actually growing there or sitting there or pooling there. So in that case, I'm looking at his history and I said, how much water do you drink? He was like, I don't. And, that's obviously never good. So I'm preparing myself mentally. I was like, oh, okay, so what's up? And he said, I only drink milk, whole milk. It's milk with all meals and milk for hydration in between meals. And again, getting his hydration reset and kind of weaning slightly off the milk and doing like a lot better hydration, that led to symptom improvement, and again, in terms of the eye doesn't see what the brain doesn't know. So one of the things that was noticeable on his scope exam was just that the saliva he was making, it wasn't purulent, it didn't look like pus, it didn't look infected, nothing like that. And again, nothing growing there, but it was much thicker. It was kind of like this viscous saliva that his body was making, as opposed to, really well hydrated and more fluid. Another quick example, this one is really huge, actually. I first saw it in 2020, where a whole run of people in their 30s and 40s were coming in and they just had this chronic throat clearing, even if they didn't get COVID that year. What's so interesting is that what it came down to in many of these cases is that the major change in their life, well, in addition to COVID, the pandemic, increased stress from that, certainly being at home, maybe with kids now at home from school, things like that. So certainly things like acid reflux could worsen from stress, but their work setup changed. It was totally out of whack. So now instead of going into the office, sitting at a work desk in a work quality chair, they were doing their work like some people said, well, I just sit at a bar stool at the counter in my home, which you have to think about positionally. That really did put those people out of whack. And one of the major contributors to their symptoms would be that they would have this cervicalgia and things like that. But again, they were sitting in a totally new, poorer posture every day and kind of like working from that standpoint. So those are all fixable things, but you do need to be thinking outside of just very literal, okay, you feel like something's stuck there. I scoped you. I don't see something stuck there. Okay, well, there's a lot that goes into the history and story surrounding these things. The last example that I wanted to share here, and honestly, it's not even related to this. It's just such a good example of a principle that Catherine Booker and I have both said, that we feel strongly about, which is the importance of a thorough history, of a thorough, accurate, thoughtful clinical history. This happened back when I was a resident, and so it's a way old story, but there was this gentleman in his 50s, and we met him under some circumstances for the ENT service, but what was interesting is that he had severe chest pain that led to a 911 call, and he was admitted for a full MI workup, which is myocardial infarction. Like truly, he was a previously very healthy, fit guy, but of course, severe chest pain, we take that very seriously. He got a full heart attack workup. It was negative. What had he done earlier that day? What were the things preceding the severe chest pain? Okay. 1, he worked out, quote unquote, really hard at the gym, end quote. He came home and ate 3 pineapples. His wife had found a deal at Costco, so for some reason, there was an unusual number of full pineapples around. And that's shortly after that is when the severe chest pain came on. So again, that clinical story, well, that totally changes it. Not to say that person doesn't get, an EKG and labs and a thoughtful MI workup, but just it makes more sense in the context of his day. And so again, these are interesting, fun things to think about. I am definitely a person who super believes in the importance of the clinical history, and we can talk more about this in the future, but I wanted to introduce this idea today for our discussion. And, from my standpoint, I see a lot of these multifactorial laryngeal problems, and so often those patients will have some element of cervicalgia or neck pain. They'll have maybe some muscle tension dysphonia, muscle tension dysphagia elements as well. Lifestyle factors and elements on history hugely inform our diagnoses. And so I say all of this too as an ENT surgeon, and I typically see patients every 15 minutes, whether they are new or not. And so we'll certainly contrast that with some elements of Catherine Booker's practice today. Today, as I mentioned, we welcome Katie Booker to the podcast, and very excited to dive in and chat with her. But first, I'd love to introduce her formally. Katie Booker is a physical therapist with a specialty in pelvic floor dysfunction. Katie received her bachelor's degree with honors in health sciences and administration from James Madison University in 1998. She then received a master's degree in physical therapy and her doctorate of physical therapy degree in 2004, both from Shenandoah University. Katie is the clinical education coordinator for Inova Physical Therapy Centers and a certified clinical instructor through the American Physical Therapy Association. She prides herself on a holistic approach to all aspects of patient care. And she's married with 2 children and 3 dogs, Bella, Fenwick, and Bethany. In her free time, she enjoys reading, exercise, and spending time with her friends and family. Hey, Katie, it's great to see you, and thank you so much for joining us today.
Thank you so much for having me, Frances May. I'm excited to be here.
Well, and we have so much, fun talking. We have a lot in common in terms of our love, certainly, for the thorough clinical history. I'd love if we could start by learning about your background and what led you to specializing in pelvic floor dysfunction.
I decided to specialize in pelvic floor dysfunction primarily out of necessity for my own personal work-life balance. At the time, our referral source for outpatient orthopedic physical therapy, which is what most people think of when they think of physical therapy, was changing. And we weren't going to get as many orthopedic patients in the clinic that we were typically used to. So in order to continue to keep our business thriving, we decided to diversify the services that we offered. And it basically, as clinicians, we just kind of sat down in a staff meeting one day and kind of figured out, based on the area and the growth of the health system that I work for and anticipated growth of them, where we could go to best serve the needs of our community. And one of those things or, areas of patient care was pelvic floor. And it was basically myself and another clinician, and we decided that was the path that we were going to choose. And we started to take continuing education classes to learn all the ins and outs of the pelvic floor and to help our patients in our community. Yeah, it came out of, both financial need, but then also what the community needed too at the time.
My understanding is that at the time that you made this move, then it was pretty much at the forefront of pelvic floor physical therapy. Like you guys were early to this party.
We definitely were early in our area. And, I had a very small exposure to pelvic floor physical therapy when I was in school. And that was in the early 2000s, like you mentioned. And there just wasn't a lot of availability for these patients with diagnoses, both male and female. So we really needed to address the needs of our community and step up and provide these services, as well as keep our business going.
Exactly. But I do think that even like this short story helps illustrate another example of something we talk about a lot on here, which is career agility and kind of like looking at the gameplay. And, you made a very strategic, thoughtful move, which benefited patients in your community, but also benefited you from your own practice and business standpoint.
Absolutely. I really needed my work to need me more than I needed my work, in the sense that I could provide a skill set for the patients in the community that would be in demand, so that I could have a little bit of say in my schedule as far as when I could be available to patients. Because at that point in my career, I had small children that, needed their mom. So I wanted to be able to be both at home as well as in the office with my patients.
I love that. I think that that's such a smart quote too. I want to highlight that. So I needed my job to need me more than I needed them.
Right.
That is very insightful. That's certainly, you were before your time. Is there any specific inspiration or, mentor who helped you have kind of like that level of acumen as a healthcare worker? Not all healthcare workers think like that,
Right. I would say definitely my first director where I work was probably instrumental in kind of encouraging me to have that sort of thought process, in the sense that she would always say, healthcare can be very circular. Management decisions can be very circular. This will always be here, but your family, your children, and all of your personal needs are going to change. And so that should always be a priority to you. And so I was able to kind of take that information, she didn't directly say it, but kind of take that thought and put it to work.
Oh, I love that. Well, and that's a skill in and of itself. Like, we get all sorts of incredible advice, but then we have to be able to apply it. And so.
Right. Yes.
Absolutely. So, for those of us, me included, certainly as an ENT, can you define and kind of explain pelvic floor dysfunction, what those symptoms look like, what that presentation is like?
Sure. So when we think about the pelvis, typically everyone is just, they think about the bones on the side and the ligaments and how the glute muscles influence the movement of the pelvis. And they don't really think about those skeletal muscles that live within the pelvis themselves. And what makes this area unique is that we can't see them. We can only feel them. But they play a pivotal part in organ function, whether it be reproductive health, sexual health, digestive health. When we think about the pelvis, we consider the bones, the ligaments, the muscles, and the glutes, but we don't consider the impact of the muscles internally because we can't see them. We can only feel them, but they're necessary for some very specific aspects of organ function. The sexual function happens there. Digestive activities, processes happen there, all the things. And so those muscles are influenced by organ function. And if those muscles aren't working well, that's going to influence organ function, whether it be digestive health or sexual health. So my scope of practice is very broad, in the sense that I can treat a male with constipation, and then the next patient on my schedule can be a female who's postpartum about 3 months. So there's a lot of variability in the patients that I treat as far as their gender or pelvic diagnoses. But what's the same is the area that I'm treating, in the sense that it's the same group of muscles. It's the same processes that all these muscles have. However, there's a lot of individual variability and uniqueness to every patient that I see.
That's awesome. And yeah, I do think that some people don't like clinic and they're never going to like it. I actually really enjoy clinic. I love the time to chat with people and kind of get to the heart of, their symptoms and their stories. But as I kind of introduced earlier in this episode, the clinical history is key. And one thing that I think is so incredible about your practice that I had learned about you is that you get 45-minute appointments with your patients. And so you have that opportunity for kind of even more detailed, intricate, thoughtful conversation with them. And my understanding even further is that a lot of pelvic floor dysfunction is related to what the patient's doing and their behaviors and their habits and so forth. So can you share with us a story when your ability to really get to know a patient over 45 minutes led to a breakthrough in clinical care? And I'm sure that you're just like, well, every day. But if you could give us some insight into those things that you look for.
Right. So when I bring a patient back, first I kind of say, all right, are you familiar with physical therapy? What do you know about this? Because I don't assume that their referring provider gave them any information. Some of them do, and then some of them don't. So I try to meet the patient where they are. And if they have had no experience with physical therapy, I need to start there. And then if they've had experience with physical therapy, I then say, okay, this is how pelvic floor physical therapy is different. And that's basically, like I was talking about before, that now we're going to talk a little bit how these organs are impacting the muscles in your pelvis primarily. And then I really believe, like you, in the importance of a thorough health history, in the sense that if I take my time and I ask the right open-ended questions and I really listen to the patient, they'll tell me what's wrong with them and they will tell me how to fix them. So I basically say, all right, here it is. Give me the story. And I just let them talk. And I always tell them, you can say whatever you want at any point, because I am fortunate in the sense that I have 45 minutes.
Right.
So I tell them they don't need to decide what's important, what's not important. That's not their job. Their job primarily is to give me all of the information and let me decide what's pursuable as far as asking more questions. So I will ask them about, activities and sports that they did when they were children, because I want to know if there was any previous trauma to the pelvis, because trauma is cumulative, right? So if a patient fell down the stairs or they were in a very traumatic car accident, 9 times out of 10, their body, their musculoskeletal system has learned to compensate for the areas in their body that was injured as a part of that accident. So over time, motor plans have changed. Recruitment patterns have changed. There's been small little compensations. They're doing little things, they're taking a lot of bladder irritants in during the day. They're not getting enough fiber. So all of these things are going to impact the pelvis and the pelvic floor function.
What sports do you find really predispose someone to pelvic trauma?
Well, I would say a lot of contact sports, obviously, but I also see my fair share of gymnasts.
Oh, sure. Yeah.
And as well as dancers, only because those activities, they live in extension, which alters the length tension relationship of the muscles in the abdomen and the back. So it lengthens the abdominal muscles, shortens the erector spinae muscles. Therefore, the pelvic floor is altered as well. My dancers and my gymnasts also aren't great at using their breath for movement. So when we're talking more about the health history, So I will also ask them, what are your favorite foods? What do you like to eat? What did you have for dinner last night? And I want to know routinely, do they eat the same thing every day? Because then I'm, kind of probing a little bit about their gut microbiome. And I want to know, how often are they having a bowel movement? And then I pull out the Bristol stool scale and I say, what does your poop look like? I always say, choose your poo.
Oh my gosh.
Yeah. Because I want to know, because, it does tell me a lot about sphincter function. If they're small little pebbles, then obviously they're dehydrated, but those muscles are not relaxing enough or lengthening enough or not bulging enough to allow stool to pass easily. I want to know about the flow of their urine. I want to know their bathroom habits. Do they take their phone in the bathroom and sit there for hours?
Yeah. Is that bad?
That's bad. That's very bad. Yeah. It creates negative tension, negative pressure on the external anal sphincter. You shouldn't do that. Do they use any type of stool for their feet while they're on the commode? That's why the squatty potty is so effective, because essentially it, shortens the muscles in and around the colon and allows them to relax in order for stool to pass a little bit easier.
Yeah, interesting.
So I want to know, and then do they strain? People have very interesting bathroom habits. The other thing that I ask about is their sexual history, any history of abuse or anything they want to share with me in regards to that. I want my patients to know from the minute that they walk in to the minute that they walk out that anything that they share with me is obviously confidential, but it's also that they are in a safe place and they get to decide what happens and what they talk about. The pelvis is a very personal area. Mm-hmm. And there's a lot of patients who come to me with, a very extensive psychosocial background or history. So I want to be sure that I'm sensitive to that. And I know before I touch them or before I examine any part of their pelvis that they're okay with that.
Absolutely. Yes. That totally makes sense. And, that's incredibly important work. And also, I think that the humanity that you bring to it, kind of like the compassion for the individual person, not just saying, hey, we're here, I'm going to examine you, right. Or, I've seen people start examining the ear without saying, I'm going to look in your ear now. Very startling to patients. They just feel a speculum go in their ear, that's right. A noxious sensation to all of us. And so of course your patients are lucky to have you because you're putting that level of, humanity into your work.
The other interesting thing that I do intentionally with my patients is I wear scrubs to work. And I do that because scrubs, providers look relaxed in scrubs. There's not as high an incidence of white coat syndrome because I'm not taking an immediate posture in the clinic to say, I'm in control, I'm the boss here. And I feel as if it really helps to disarm my patients in such a way that they can tell me some of these things that they're just embarrassed to talk about. Because culturally, we don't talk about our bowel and bladder habits as often as what we should. And so folks don't know what's normal, what's not normal. And I tell my patients a lot, things are very common, but they're not necessarily normal.
Mm-hmm. Oh, I love that. Yeah, that's very true. One thing that I wanted to touch upon today is just the fact that we probably have a greater overlap, in patient populations than I had initially appreciated because, and you could probably see from my face, the more you talk about poop, the more I'm like, this is exactly why I became an ENT. I don't ever want, it's funny, but the comorbidity of pelvic floor dysfunction and TMJ, I find so interesting.
Yes.
And so I'd love to hear anecdotally how much you see that in your practice. What do you think is the link between the two? Is this supratentorally mediated? I'm very interested. I was kind of looking at the literature for that, although a lot of it wasn't in mainstream medical journals.
Right. So I screen all of my patients who have a medical diagnosis of constipation for any type of TMJ dysfunction. And anecdotally, the vast majority do. Or they have a history of bruxism.
Wow.
And they wear a night guard. Why is that? I think it has to do, like, we can get clinical and we can say that, neural tube development, but typically, the tube, if the tube is tight, going in, then the tube coming out essentially is also tight. And these patients historically can have a history of cervical spine dysfunction. But primarily, what I've seen clinically in my patients with a history of constipation is that they're using their diaphragm as a postural muscle. So their diaphragm has lost that ability to, be the pump, be the secondary pump. So not only to move, for the lungs to expand, but also to help the nervous system regulation for the stool to move through the colon. In physical therapy, we view constipation, anything with defecation as a movement concern. So we're looking at how that patient is accomplishing that bowel movement on that particular day at that particular time. And those patients that report constipation or a history of bruxism, or they wear night guards, I look at their compliance with wearing the night guard. I look at their fiber intake. What's the balance between soluble and insoluble fiber? And then the other clinical anecdote is these patients are typically very intense exercise participants. So they're doing the high intensity interval training, or they're running, 2 and 3 times a day. So there's a lot of stress being put on their nervous system, meaning that they are driving primarily their sympathetics. And so there's not a lot of rest and digest happening. Wow. So we talk about mindfulness, we talk about stretching, we talk about breathing. The only clinical supported breathing approach is circular breathing. And this came out of, and I apologize, I don't know the author's name off the top of my head.
Oh, that's okay. We can link it later in the show.
Okay.
No problem.
But it talked about the most beneficial breathing as far as creating that heart rate reserve, which is super important for everybody to have, our heart rate variability, I should say, is circular breathing performed 6 times a day, 2 minutes, where they breathe in for 4 seconds and then they exhale for 6 seconds. So that's helping to stimulate the vagus nerve, stimulate the pumping motion of the diaphragm, as well as support nervous system health so that the parasympathetics can become a little bit more resilient. And sure enough, we can have bowel movements without stress and strain.
That's amazing. You probably see me here. Now I'm like thinking really hard. I'm sitting here trying to breathe. I'm definitely a person who forgets to breathe and like maybe lives in the parasympathetic state. I'm trying to fix that. So that's very helpful. But I can't believe like that 2-minute circular breathing practice. You said 6 times a day?
6 times a day, which, I mean,
oh my gosh, come on.
Right. But we have 2 minutes. Sometimes that's a huge piece of time for a patient to take on and digest, but I'm like, you've got 2 minutes. I don't care so much about the 6 times. If I can get you doing it, 3 times a day, I'll take it. Our bodies don't know when we're doing good things for it. It just knows that we're doing something. Okay. It's just our brain kind of gets in the way. So we just need to create environments and create habits that will support, making positive decisions and positive things for our health.
I love that. But you're so right. Like the brain doesn't know that that's good for it because like you say that and I'm like, what? Homework? 6 times a day homework? Like, absolutely not. Then my to-do list is already, quite hefty. But I do want to, I really appreciate, your explanation of that because that makes sense. And it helps me even because I see TMJ certainly multiple times a day, most clinic days. More than once a day. And, bruxism for everyone, that's where we grind at night. And then I see, of course, a ton of clenching during the day. I was actually having a conversation with my audiologist just recently because we saw this patient where it's so funny, they'll tell the nurse, nope, never had jaw trauma, never had TMJ, and I don't grind my teeth. And they told the audiologist as she was doing a full workup, audio and tympanometry, for bad ear pain. Never hit my jaw, like no jaw trauma, no bruxism, no clenching during the day, nothing like that. But it's so funny because one thing that has really made a difference in my practice is that in addition to all those questions, I start giving super concrete examples. I will ask people, have you ever flipped over handlebars when you were a kid? Because what I'm getting at is I want to know, did they ever hit the underside of their chin on something? Because, not uncommonly, people will be like, you know what? Yes, I have flipped over a scooter or I've flipped over a handlebar or, hey, and then they'll point to a horizontal scar under their chin. Not one that just anyone would see, but, they'll show you and they'll say, that's true. Like when I was a kid, I did hit this really badly. And now they're presenting with, signs of TMJ joint derangement. And one of the reasons is because, of course, that mechanism of injury, it kind of drives up both TMJs, up into the joint. But that's such one that we don't even think about because that's not trauma directly to the joint itself. Although I've had people say, yeah, I opened up or a door at home opened up right into my TMJ and it's been hurting ever since. And I'm like, yeah, that's pretty much a slam dunk. Like that sounds like that's what it is. You hit it right on the joint.
Right. So in physical therapy, if I were to hear something about that, now I'm considering, okay, well, how have they modified? Obviously, there was some sort of trauma to that area. So now what does their breathing look like? What does their posture look like? How do they deviate when they open their jaw? What are their pterygoids doing? So that's an example of, something traumatic, how the body has learned to kind of go around that trauma and develop motor plan compensations that can be pretty significant long term. That's probably my favorite part of the kind of work that I do. And I tell my patients, I'm always trying to figure out who's driving the bus. And, I just start digging and, layer after layer. Sometimes I will say that they're like onions and they can make me cry, but I'm just peeling back all of their various compensations and trying to figure out the primary driver for whatever dysfunction they happen to be showing. And a lot of times constipation is a big driver for any type of urinary issue, just because of real estate in the pelvis. There's only so much space. So if the bowel is distended with stool, it's going to push on the bladder. So you're going to see a lot of increased urinary frequency. And if you layer on some bladder irritants and not a lot of water intake, these patients are going to the bathroom a lot. And therefore, they're decreasing their bladder capacity and their pelvic floor muscles are getting weak because they don't get the opportunity to do their job, which is to keep those sphincters closed.
Wow. This is more than I ever thought I would learn, but I really it makes perfect sense and it's super useful. Like this is honestly, I guess I should have been putting probably more thought into this because it definitely, I'm sure more patients than I know do deal with this, even when they come into me for the TMJ side of things. Like, yes, they're two ends of kind of the same tube. So it does make perfect sense. One thing that I wanted to move on toward, and it's certainly tangentially related, is that I love the quote, if you don't make time for your wellness, you will be forced to make time for your illness. And so I'd love to hear your thoughts and interpretation of this old adage. Like, is it true? Is it not?
Oh, it's 1,000% true. I actually have a poster in my office with that same sentiment that it says, if you don't pick a day to relax, your body will pick it for you. So same sort of thing. Our body's always giving us information about what we're doing, how we're doing things. And if we're not paying attention, then we can develop some pretty interesting habits that can long-term not serve us in the best way. And that's how patients necessarily or can end up in my office. The incidence of pelvic floor dysfunction, especially, if you think about women, prolapse, especially, it's 40 to 60% among women who have children. So that's a lot. That's a lot. And that's just considering, one pregnancy, and that does not account for how the baby is delivered. It's just the actual stress and strain on the pelvic floor that can lead to the pelvic organ prolapse.
It happens to 40 to 60% of women who have kids?
Right.
Oh my gosh.
Yeah.
At first, I hoped you just meant 40 to 60% of people who experience prolapse have had kids, but no, much more. Oh my gosh.
Correct. Yeah. So, I mean, culturally, I would say that we're definitely changing a lot of habits, but previously we just didn't talk about that, which is why, there's all these products in our stores to assist with any type of issues related to pelvic floor dysfunction. So with prolapse, you can get, the a cystocele or a rectocele, which basically are named for which part of the vagina, the vaginal wall, is now, visible at the introitus. And when I see that clinically, I always tell my patients, this looks like this is happening, but I'm very cautious that I don't practice medicine without a license and say, oh, you have a cystocele, because that's not my call to make. That's for the physician to say, but I treat them as such. And so we talk about, supporting the muscles in and around the pelvic floor. But yes, the incident rates around prolapse are very high.
I'd love to shift to discussion of your very important work as the site coordinator for clinical education. So can you tell us about your role, the responsibilities, and all the different centers that you oversee?
Yes, I'm in charge of soon to be 18 centers that I take physical therapy students who have completed most, if not all, of their didactic information and now are essentially ready to be in the clinic with their clinical instructor. We typically make those decisions March, April, and then students start their placements the following year, meaning this past March and April, I was placing students for 2025. So it's a bit daunting that I'm working that far ahead, but schools need enough time to know what potentially would be available. And it's
right.
And it's very dynamic. It's very much like my daily patient care schedule that it changes a lot. Placing a student with a clinical instructor is a lot like dating. So I kind of feel like a matchmaker because I want to make sure that the CI gets a good student as well as the student gets a good CI. And ultimately, they are able to learn from each other. I really enjoy that part of my job, just seeing the aha moments happen with the students as well as the CI, getting a little bit more of the warm fuzzies as far as, professional growth and seeing how what their knowledge is impacting the future generations of physical therapists.
That's incredible. Do you feel like you have enough information from both sides to matchmake?
Sometimes. And sometimes if I don't feel as if I do, I'll reach out to the school or the student and say, tell me a little bit about your learning style. A lot of the PT schools will provide that information for me, but if it's not sufficient or I just want to know a little bit more about the student, I will just reach out to them directly.
I love that. That's incredible. I'm not sure that any med school matches people that way. Right. We just kind of like, no one is like, what's your learning style? And then usually if you say your learning style, you just get like yelled at or something. Right. I'm a little bit kidding, but I'm not 100% kidding. Right.
Well, we don't have that in physical therapy. I mean, we are always, we're kind of seen in medicine as, we're the nice guys. We're the movement doesn't have any negative side effects, folks. So we try to ensure that our students are placed in settings with instructors that are only going to help them develop their own clinical thinking and reasoning.
What differences do you see in working with this next generation of physical therapists compared to when you came up?
Right. So I really enjoy working with the physical therapy students that are kind of, at the tail end of their education, because they're really going big picture. When I was in school, it was more about like, okay, I'll get a job. Great. Okay, what do I have to do? Show me the hoops. I'll jump through it. I didn't question anything. I didn't ask for anything. I just kind of took whatever they were offering. And I would say now with therapists, they want to know the why behind a lot of the decisions that we're making. And I enjoy that challenge. I don't see it as disruptive or disrespectful. And I don't respond to it with, well, that's how it's always been. So I try to give thoughtful responses to those types of questions. And then I ask them, do you think that there's a better way? A lot of times, especially in staff meetings, if we have a student in clinic that where I'm working, and somebody says, well, students really like this, I will say, well, why don't we ask the student that we actually have in the clinic if they agree with that statement? So I think including them and asking for their feedback, they're willing to provide it if we give them the opportunity and the space to really speak their mind. It's interesting because we're talking about health and well-being at work. And an interesting contrast that's come up just with us, with our staff at work, is I perceive, I'm Gen Xer, health and well-being is I don't have to fold laundry anymore. I have pretty consistent opportunity to park my car in the same place every day when I come to work. So to me, that's health and well-being. Whereas some of my younger cohort therapists will perceive health and well-being as more productivity requirements. And do they have time for, seeking out just breaks, just a lapse in their schedule where they can kind of clear their head for a couple minutes. And so it's very different how all of the generations and all of the clinicians perceive, the workplace and the challenges that each workplace provides, the generations, I should say.
Yeah. Well, but first of all, thank you so much for not being a person who says, as a response to a question, because that's how we've always done it.
Right.
I could just you're VIP of this whole week, because I think that that's part of the start, like in healthcare, especially for healthcare workers. Not everyone is so open-minded, but I do think that, it's wonderful to chat with you and connect with someone like very brilliant. You have to be confident to be open to these conversations. I actually interpret it as a lack of confidence when people kind of, issue a question, or they say, because that's how we've always done it. It's like, they actually may not know why we do it this way. Like, you honestly may have caught them with their pants down. Like, they don't know. But instead of saying, hey, I don't know, there's a lot of, I see this all the time, like the willingness and the ability and the action of saying, I don't know, I'm not sure. Oh, let's go ask someone else, or we'll go look it up, or we'll go talk about it. That is a sign of intelligence and competence.
Right. Yeah. I don't know is an answer, right? I mean, it is. And so I think allowing yourself to be vulnerable in that moment is okay. And I think it's definitely something that's, respectful if you're working with, colleagues that are younger and say, I'm not sure, but let's explore that. Or do you have any ideas on how we can make this process better?
Yes. And I say that all the time. I literally think I said that in clinic this morning, just in terms of, I'm in solo practice at a rural community hospital, and we also are the only clinic that takes all the insurances for just like hundreds of miles. And so we get genuine conundrums, and they're not just clinical conundrums. They're like societal, there's like social determinants of health at play. There's like support systems that maybe are at play as well. And so we will even talk as a group, and I will say to the whole team, I'm like, what do you guys think? Like, okay, well, let's think this through. I guess we have these two options. What do we think of the pros and cons of each? And so just getting feedback from other people, I think, only strengthens the healthcare team. like approaching this as a team. And I think we all have very vested interests in our patients doing well from our ENT clinic. Like we all care about that. Every single woman who works in the office.
Right. And I would also say that the current younger generations, they're more collaborative, which I really appreciate. It's not, whereas before it was, when I was first started with my career, if I had a question, I had to dig deep to find the answer on my own. And now I feel like I have this team that I can turn to and say, what do you guys think?
Yeah. So some things are moving in the right direction, and hopefully they continue to do so, but they will as long as the people in leadership positions and the people who are role models for the next generation display these qualities. So, certainly your students are lucky to have you as well. What advice would you have for the next generation of physical therapists?
To always be curious. Definitely. To not become complacent with patient care. Still be excited about it. I think if at any point you don't have that kind of fire in your belly where, going to clinic is exciting, then you really should step back, because that's not fair to the patients that's sitting in front of you. You want to be curious as to their why, what's their driver? Why are they showing up in your office? I mean, at this point, the physicians have done an excellent job of ruling in and ruling out, medical things. And so they're coming to you with a likely a diagnosis that's causing them some psychosocial stress. So taking the time to really dive deep and, that thorough health history and figure out why they're presenting the way they are. So curiosity is definitely the key to, I think, longevity in physical therapy, as well as possibly, all aspects of healthcare.
Definitely. That would be a big part in medicine. And arguably though, even from a brain health and cognition standpoint, curiosity is the answer to longevity for us, for you. So, all around, that's wonderful. Thank you again for joining me today, Katie. It's been such a joy to learn from you, even about poop. Even that, the fact that you've made even that very understandable, very enjoyable to learn about is like a testament to your skills. Follow me on Instagram at francismay.md and at Rethinking Residency. Visit my website, rethinkingresidency.com, to learn more about resident physician stories and ways that residents can most effectively navigate the game of residency. I cannot wait to connect with you on the next episode of Promising Young Surgeon.